Hello, everyone. Hope you're all well, and welcome to our channel Obstetrics and Gynecology Training. I'm Himanshu Borse. I'm working as a consultant gynecologist and fertility specialist in the UK. And the purpose of these educational videos is to help anyone and everyone who is interested in learning more about obstetrics and gynecology. If you like our videos, I would recommend please do subscribe and like this channel. And if you want any specific topics to be covered, please do let me know so we can cover them in near future. My apologies, it's been a long time. Um, I'm coming back with another video, but in future I'm hoping to be more consistent with different topics. So today we are going to talk about menstrual cycle, and I have always told my trainees, juniors, that menstrual cycle is the most important part of obstetrics and gynecology, and once you understand it better, majority of the conditions you will be able to understand in a much better way. And this is an attempt to sort of talk about it in more detail. My apologies again for a long video, but what I have tried to cover is menstrual cycle, the changes, and the hormones in detail. So in future, obviously, I'll keep in mind to keep them short and sweet. Thank you. So, evolution of the menstrual cycle. So, why do humans menstruate? So, they looked at it because in non-human animals, usually the embryo sort of drives the pregnancy. So, if you look in lamb, in sheep, the lamb decides how the pregnancy progresses and how the labor starts. However, in humans, because of the evolution, things changed a bit. So the menstruation occurs as a mechanistic consequence of hormone-induced differentiation of the endometrium, which is also called as spontaneous decidualization. Now, it evolved because of maternal fetal conflict. It evolved by genetic assimilation of decidualization reaction, which is induced by the fetus in non-menstruating species. To understand why menstruation evolved, we have to think of it as a byproduct of spontaneous decidualization. In most mammals, the thickening of the uterine wall is controlled by the embryo, as we already discussed, and it occurs in response to fertilization rather than in preparation for it. Whereas in humans, decidualization is one way the parent tries to wrest back dominance of their uterus from an increasingly invasive embryos. The uterine lining now responds only to the parent's hormone rather than the embryos, and the parent controls whether or not they get pregnant. If you remember that we learned that embryo is genetically a different material and mother's immune system could fight it, and that's why there is a chance of rejection of the embryo, and that is a new concept coming, and people are working on immunization therapies to increase chances of pregnancies in women with recurrent miscarriages. So in humans, they put their defenses up preemptively by sealing off the main blood supply from the endometrium before the embryo implants there. And not content with this, the embryo is evolved to burrow through the endometrium until it reaches the arteries, where it tears through the wall and rewires the blood vessels so that it can bathe directly in the parent's blood. And as you'll appreciate, trophoblast is an extremely invasive tissue. It is designed to invade its surrounding, and that's the reason you get placenta accretas and percretas, where placenta crosses the uterine wall beyond into the lateral pelvic wall, or sometimes placenta has been shown to be implanted on bowels. And that's how the abdominal pregnancies would sometimes continue. There are case reports of an ovarian pregnancy gone till term with 3.5 kilo baby. So, which other animals menstruate other than humans? So, gorillas, baboons, bonobo monkeys, elephant shrew, which is actually not an elephant but a rodent, and bats. Quite interesting. So, as we all know, it works on HPO axis. So, hypothalamus, pituitary, ovarian axis. And now we are going to look at it one by one. So, hypothalamus and GnRH secretion. So, hypothalamus is the part of the diencephalon at the base of the brain that forms the floor of the third ventricle and part of its lateral wall. And it has a preoptic area, suprachiasmatic nucleus, paraventricular, and supraoptic nucleus. The neuroendocrine cells that produce GnRH, they originate from the olfactory area or the developing brain. And by migrating during embryogenesis, these cells move along cranial nerves connecting the nose and the forebrain to their final location, where eventually 1 to 3,000 GnRH producing cells can be found in the arcuate nucleus of the hypothalamus, extending their axons to the median eminence. And disturbance in this amazing journey characterize the clinical entity Kalman syndrome, which we must have all heard of. A failure of both olfactory axonal and GnRH neuronal migration from the olfactory placode results in the absence of GnRH as well as defects in the sense of smell that are characteristic of a Kalman syndrome. Like olfactory epithelial cells in the nasal cavity, GnRH neurons have cilia. The olfactory origin and the structural similarity of GnRH neurons and nasal epithelials suggest an evolution from reproduction controlled by pheromones. The half-life of GnRH is only 2 to 4 minutes. So GnRH is a small peptide. It only contains 10 amino acids with some variation in amino acid sequence among different animals. And the follicular phase of the menstrual cycle is characterized by a higher frequency, so it would go a bit faster, but the amplitude would be low compared to the luteal phase. And this slowing of GnRH pulse frequencies in the late luteal phase is an important change, favoring FSH synthesis and secretion over that of LH. This transition is GnRH pulse characteristics allows the rise in FSH that is essential for the next cycle. And you will see in next few slides that why this frequency is important. Before puberty, the GnRH is constantly raised, and that's why there is no FSH and LH secretion, and that's why there is no menstruation. However, once an ideal body mass is achieved, along with fat storage, the fat cells secrete leptin hormone, which tells the brain that now the woman is ready to reproduce, and that's when the pulsatility of GnRH secretion comes into place, triggering the menarche. Now, this frequency is important, and that's why in a majority of women, except the ones with PCOS, you will see that FSH is always higher compared to the LH, except during the LH surge part. And that's where this higher frequency but a smaller amplitude, whereas in PCOS patients, the frequency is altered as well as the amplitude is altered, which favors more secretion of LH compared to FSH, and that's why this ratio is skewed in PCOS patients, which leads to oligo or anovulation. GnRH agonists, the initial agonistic action is leading to a flare effect, which is increasing circulating levels of LH and FSH. And this response is greatest when the agonist is administered in the early follicular phase of menstrual cycle, when GnRH and estradiol have combined to create a large reserve pool of gonadotrophins ready for secretion. And after 1 to 3 weeks of continuous presence of this agonist, the desensitization and downregulation of the pituitary occurs, resulting in hypogonadotrophic hypogonadism, meaning low LH, FSH, as well as low estradiol levels. The initial suppressive response is due to desensitization, whereas the sustained response is due to the loss of receptors and the uncoupling of the receptor from its effector system. And there are various trade names: leuprolide, goserelin, triptorelin, histrelin, which are used in different conditions. The antagonist, whereas they competitively inhibit the action straight away, and that's why their effect is very quick and visible within 24 to 72 hours. Although the early products which were produced, they lacked the potency or were associated with undesirable side effects due to the histamine release. But obviously now new research is coming into, and that's why better products are there. And we know that these are effectively being used in treatments of endometriosis, prostate cancer, precocious puberty, and female infertility. And they are antagonins, cetrorelix, cetrotide, algolix, ganirelix, and people working in IVF must be very familiar with cetrotide. Now, brain and ovulation. So, lower GnRH pulse frequencies, such as in the late luteal phase, favor FSH secretion, and higher GnRH pulse frequencies, which occur in late follicular phase, favors LH secretion. Low levels of estrogen enhance FSH and LH synthesis and storage, and have little effect on LH secretion and inhibit FH secretion. High levels of estrogen induce the LH surge at mid-cycle, and high steady levels of estrogen lead to sustained elevated LH secretion. And that's the reason that in PCOS patients, the estrogen is high and the LH is high as well. Low levels of progesterone acting at the level of pituitary gland enhance the LH response to GnRH and are responsible for the LH surge at mid-cycle. High levels of progesterone inhibit pituitary secretion of gonadotrophins by inhibiting GnRH pulses at the level of the hypothalamus. In addition, high levels of progesterone can antagonize pituitary response to GnRH by interfering with estrogen action. Now, the FSH hormone, as the name suggests, it's called follicle stimulating hormone, and it is produced by anterior pituitary in response to the GnRH hormone, and it plays an important role in sexual development and reproduction in both men as well as women. It's a glycoprotein dimer which has got an alpha and a beta chain. The beta subunit is unique to FSH, whereas the alpha subunit is same for all of them: LH, FSH, TSH, and HCG. And that's why, if you remember, that when you're seeing any patients in early pregnancy, you are doing beta HCG for them and not just HCG, because the beta subunit will be unique to HCG. If you measure alpha, you're going to measure all these four hormones, which will be erroneous. Now, GnRH stimulates FSH release. The hypothalamus produces GnRH, and it's released into hypophyseal portal circulation to act on G protein coupled receptors at gonadotrophic cells of the anterior pituitary. Those gonadotrophic cells produce FSH and luteinizing hormone and release them into the peripheral circulation. Excuse me. Now, the GnRH release occurs in a pulsatile manner with low pulse frequencies stimulating more FSH production and high pulse frequencies stimulating LH production. And the continuous use of GnRH suppresses the release of FSH and LH from pituitary, which inhibits ovulation and estrogen production in women. And clinically, GnRH agonists like leuprolide work via this mechanism. In women, negative feedback from estrogen levels inhibits FSH secretion. So, as the FSH is coming, we are going to go in detail later on about this, but simply is GnRH stimulates pituitary, it produces FSH. FSH stimulates ovaries, the follicles produce estrogen. Estrogen feedbacks to the brain that there is enough estrogen, don't push the ovary, and that's why FSH secretion is controlled. In men, levels of inhibin B secreted by the Sertoli cells in response to FSH inhibit the FSH secretion via negative feedback. So in women, estrogen leads to a negative feedback for FSH, whereas in men, inhibin B does the same job. During the fetal development, these GnRH producing neurons develop from the epithelium of the medial olfactory pit and then migrate to the hypothalamus. The anterior pituitary gland develops from Rathke's pouch, a portion of the oral cavity, whereas posterior pituitary is extension of the brain itself. So even though pituitary we call it as one organ, developmentally anterior pituitary is developing from Rathke's pouch, which is ectodermal, whereas the posterior pituitary is the extension of the brain. In second and third trimester of pregnancy, as well as during the first 3 to 6 months of infancy, the pituitary gland secretes LH and FSH. And these levels peak mid-pregnancy as the first ovarian follicle or seminiferous tubules mature. In males, the FSH stimulates Sertoli cell proliferation, which is the most significant contributor to the testicular volume in children. The Sertoli cells produce an AMH, which causes the involution of Mullerian ducts, preventing the formation of female internal genitalia. Clinical correlation of the early infancy LH and FSH surge can say the lack of normal infancy peak of LH and FSH might identify and diagnose infants, especially males who have hypogonadotrophic hypogonadism. Girls with monosomy, like Turner syndrome, have an elevated FSH up to 6 years due to the lack of negative feedback from non-functional ovaries, while girls who are mosaic Turners have a much lower FSH elevation due to the partial ovarian function. And for the same reason, mosaic Turners will become prematurely menopausal at varying degrees and at different ages, depending on what percentage of their mosaicism is related to Turners. You need both X chromosomes to maintain the pool of primordial follicles in women, and that's the reason that women who are born with Turner syndrome, where one X chromosome is missing completely, their follicles have been depleted even before they are born, and what they are left with is just the skeleton of the ovaries, which we call them streak ovaries. Whereas women who are mosaic, so that means not 100%, but certain percentage of their cell line is XX, whereas certain percentage is X0. So depending on that percentage, they will become menopausal at different ages. During puberty, the hypothalamus secretes GnRH in a pulsatile manner, which stimulates the anterior pituitary to increase secretion of LH and FSH. So in females, it is needed for estrogen production and follicular development, whereas in males, it is needed for induction and maintenance of spermatogenesis. FSH stimulates granulosa cells in the ovarian follicles to synthesize aromatase enzyme, which converts androgens produced by the thecal cells to estradiol. And FSH, along with testosterone, is necessary for maintaining normal sperm count and function. And studies have shown that FSH deprivation not only lowers the sperm count, but also affects the quality of the remaining sperm. Elevated levels of FSH are associated with unresponsive gonads or hyperfunctioning pituitary adenomas, whereas low levels of FSH are associated with either hypothalamic or anterior pituitary dysfunction. So where do we see the issues with FSH? Obviously, infertility, sexual development, amenorrheic patients, menopausal patients, and patients with pituitary adenomas. And all of these patients, the FSH will be altered. If males present with small firm testes and azoospermia or oligospermia, so high FSH meaning it could be either Klinefelter syndrome from hypothalamic or pituitary insufficiency. If testicular size is normal and the patients present with azoospermia or oligospermia, FSH levels can be used to determine whether the cause is a primary impairment of spermatogenesis or obstructive. Meaning, if somebody has severe oligospermia or azoospermia and their FSH is high, that means the problem is with the production of the sperms, that means there is something wrong with the testis, either mum's trauma or whatever. Whereas if the FSH is normal, that means the production is most likely happening fine, but the transport of the sperm from testis to outside is affected by obstruction. So it could be cystic fibrosis or some surgeries like that. Several FSH preparations have been used to treat secondary hypogonadism in males. These preparations have been reasonably successful at inducing spermatogenesis and achieving paternity. And people, again, who are working in infertility would have seen that sometimes in men, to trigger sperm production, we treat them with Clomid, obviously after careful assessment and finding the cause. So as we talked about earlier, PCOS. So PCOS, all we know that the Rotterdam criteria is oligo or anovulation, meaning no ovulation or irregular ovulation, polycystic ovaries on the scan, and biochemical or clinical evidence of hyperandrogenism. And patients with PCOS often present with hirsutism, obesity, insulin resistance, menstrual irregularity, and infertility. In PCOS, the LH and FSH ratio is skewed due to persistently rapid GnRH pulses. These GnRH pulses lead to an increased LH-FSH ratio, and this skewed ratio leads to theca cells of the ovaries producing excess androgen, while granulosa cells do not produce enough aromatase to convert the androgens to estradiol. Hypogonadotrophic hypogonadism, in cases of amenorrhea with low levels of FSH-LH, the fault lies with either the hypothalamus or pituitary, or we call them central causes. Stress-induced hypopicture. When the calorie intake falls short of energy expenditure, the physiological stress decreases hypothalamic GnRH pulse frequency as well as amplitude, leading to low FSH and LH levels. And this explains the anovulation and amenorrhea that occur in female athletes and individuals with eating disorders due to lack of adequate calorie intake or excessive exercise. And similarly, in countries where women are most likely going to be malnourished for various socio-economic reasons, we face the same issues. Kalman's syndrome, as we learned earlier, that the GnRH neurons are developed along with the olfactory neurons, and when this migration is affected, it leads to Kalman's syndrome, where the patient has a deficient smell as well as menstrual issues. In primary ovarian insufficiency, the FSH levels will be very, very high, and obviously the problem will be the ovaries because they are not responsive. Whereas premature ovarian failure occurs when it happens before the age of 40, where a similar picture is seen, where FSH is very high because there is no feedback. Most of the times, these patients are suffering from that because either they're Turner's or Turner mosaics, but majority of the times we don't find any reason. And the genetics is very important here, because if someone's mother was menopausal at 40, the daughter is most likely going to be menopausal around the same age. Turner syndrome is the most common genetic disorder causing premature ovarian failure, where one X is lost, and these girls will present with primary amenorrhea and streak ovaries with very high FSH levels. And again, depending on the degree of the syndrome, they will exhibit some other symptoms as well. Pituitary adenomas, these are the tumors arising from the pituitary. So either they could arise from the gonadotrophs or the other cell lines, but usually they are non-functional, and they are mainly detected because of their pressure effects on the optic chiasma. Medications affecting FSH. So agonists and antagonists, as we learned earlier, the agonist and antagonist work in different fashion, and agonists can take a while to suppress the pituitary activity, whereas antagonist can achieve that effect in less than 24 to 72 hours. We use FSH in IVF, very common, and apparently it has been shown to be useful in various other conditions as well. Now, the LH hormone, luteinizing hormone, it's a glycoprotein hormone that is co-secreted along with FSH, and in both sexes, it contributes to the maturation of the primordial germ cells. In men, LH causes Leydig cells of the testis to produce testosterone, and in women, it triggers the ovulation and formation of corpus luteum. It also helps to regulate the length and order of menstrual cycle by playing roles in both ovulation as well as implantation. In males, LH stimulates testosterone released by the Leydig cells, and in females, it causes ovulation and formation of corpus luteum. Estrogen is a steroid hormone associated with the female reproductive organs and is responsible for developing female sexual characteristics. Estrogen is the most common form of estrogen hormone for FDA approved treatment in HRT for the symptoms associated with menopause. Estrogen also causes development of the mammary tissue as well as parenchymal and stromal changes in breast at puberty, which we call thelarche. It is also responsible for the development of mammary ducts during puberty and pregnancy. It also functions to secrete breast milk in postpartum lactation. In uterus, estrogen helps to proliferate the endometrial cells in follicular phase of menstrual cycle, thickening the endometrial lining in preparation for pregnancy. And we know that in contraception, estrogen and progesterone stop the ovulation by affecting the pituitary pathway. For vaginal epithelium, it is needed for proliferation of both vagina as well as vulva, and in its absence, they become atrophic, which we know as vulvovaginal atrophy. Estrogen is required for maintaining the bone density, and it has a protective effect on the myocardium, and that's why we see that prior to menopause, the incidence of heart diseases is very high in men, as much low in women. But after menopause, it's more or less same in both sexes. So it does offer protective effects on myocardium as well as by favoring the HDL and LDL triglyceride levels and reducing the LDL lipoproteins. It can be administered as orally, vaginally, or as an intramuscular injection or transdermal patches. The side effects list is very exhaustive, but the common ones are breast tenderness, nausea, vomiting, bloating, increased risk of DVT, irregular bleeding, and the list goes on. The contraindications for any estrogen therapy are estrogen hormone receptor sensitive malignancies, including breast, ovarian, and endometrial cancers, heart diseases, history of DVT, or any hypercoagulable conditions, history of ischemic strokes, migraines, seizure, and dementia or neurocognitive disorders. Hypertension, fibroids, endometriosis, incontinence, hyperlipidemia, gallbladder disease, liver disease, tobacco use. Again, probably it is related to the hypercoagulability, and it is not used in pregnancies. The clinical uses in primary ovarian insufficiency, where women are experiencing menopausal symptoms, female hypogonadism, so that they can develop the secondary sexual characteristics, symptoms associated with menopause, contraceptive pills, moderate acne vulgaris, and prostate cancers with advanced forms of metastasis. Progesterone hormone is an endogenous steroid hormone that is commonly produced by adrenal cortex as well as the gonads, which consists of ovaries and testes. Progesterone is also secreted by ovarian corpus luteum during the first 10 weeks of pregnancy by the time the placenta takes over. The conversion of progesterone generation from the corpus luteum to the placenta generally occurs around 10 weeks of the pregnancy. One of the primary responsibilities of progesterone throughout pregnancy is to maintain a decreased level of vascular tone in the myometrium, and that's why women get the symptoms of pregnancy, because progesterone relaxes the smooth muscles. So its job is to keep the uterus quiet until it goes in labor. And unfortunately, progesterone doesn't exactly understand what is myometrium and what is not. So it practically relaxes all the smooth muscles in the body. And that's why women's esophageal sphincter is relaxed. That's why they get reflux. The bowels are relaxed, and that's why they get constipated. The urethral sphincter is relaxed. That's why, with advancing pregnancy, they sometimes get incontinence. The progesterone also influences production of inflammatory mediators such as human T cells within the uterine cavity, and that's why the luteal phase defect condition is supposed to happen, that progesterone is lacking to support the pregnancy, and that's why we support them with external progesterone supplement. As we talked about it earlier, its main job is to prepare the endometrium, keep the uterus quiet. It also has a role in menstrual cycle, and it additionally causes the cervical mucus to thick and preventing um, entry of the sperms, as well as the mucus plug protects the pregnancy from external environment and the bacteria. And in males, progesterone functions to facilitate spermiogenesis and androgen synthesis. It has also been studied regarding its protective effect on various neurological disorders, osteoporosis, benign prostate hyperplasia, and osteoporosis. In the setting of the nervous system, progesterone plays a role in myelin proliferation, whereas in the musculoskeletal system, the steroid hormone interacts with estrogen to form an equilibrium for peak bone mineral density. The link between progesterone receptors and benign prostate hyperplasia has support from the expression of progesterone receptors in the prostate gland. Combined with estrogen, it has been used as contraceptive pill. It can be used to treat secondary amenorrhea, anovulation, and endometrial hyperplasia. In dysfunctional vaginal bleeding, once a diagnosis is established, and as long as it is not a cancer, it can be offered as a treatment. And these indications are related to the reproductive effects of progesterone. However, progesterone can be used in non-reproductive applications also. For example, they have been used to treat hypertension and COPD. Additionally, there are citations of its use to treat drug dependence also, specifically cocaine and nicotine. Its side effects are abdominal cramps, back pain, breast tenderness, hypotension and dizziness, hypercoagulant state, and vaginal bleeding. So now, the actual part of the menstrual cycle in detail. So, as we talked about it, it happens at hypothalamo-pituitary ovarian axis, but it is also leading to changes in uterus as well as cervix. So, this is one of my most favorite diagrams, and once you understand this diagram and menstrual cycle, you will understand gynecology in a much better way. So as you can see here, that once the menstruation starts, the follicular phase starts, and you can see that the FSH hormones starts getting secreted, and as the name indicates, it's a follicle stimulating hormone. So now it is going to the ovaries and select a cohort to be stimulated. We still don't know how this selection happens, but it has to do with number of FSH receptors on the primary follicles, and those with a higher number are going to respond better. And in each cycle, a certain cohort is selected and the follicles start growing. As these follicles start growing, the estrogen level goes up as it is getting secreted by these growing follicles. And these follicles have a negative feedback for FSH hormone. But this estrogen is increasing the thickness of endometrium by proliferating the endometrial lining. And that's why it is also known as a proliferative phase. Now, it has a negative feedback on FSH, but it has a positive feedback on LH. So once the estrogen reaches a certain level, it starts enhancing the secretion of LH, which leads to the LH surge. And this surge is responsible for the ovulation. But other than ovulation, it does one other important job, is the LH surge actually triggers the first meiotic division of the egg. And at the time of ovulation, the first meiotic division happens and the first polar body is released. And the second meiotic division happens exactly at the time of fertilization, and that time the second polar body is released. And that's why this LH surge is very important, and for the same reason we have to mimic this LH surge in IVF treatments by giving HCG externally. Now you might be surprised that how LH surge can be mimicked by HCG. So we talked about it earlier that LH, FSH, TSH and HCG, they all have same alpha subunit, and even their beta subunit is more than 90% identical. So we use HCG as a surrogate of LH. The other thing is the LH can be produced only by a recombinant technology, which means that a recombinant LH is very, very expensive, whereas the HCG is collected from pregnant women's urine, so it's much cheaper. And that's why, to keep the costs of IVF down, we use HCG as an LH surrogate. Now, as the ovulation happens, the follicle collapses and it is filled with fat cells. And under microscope, it looks yellow, and that's why it is called corpus luteum, which literally means yellow body. And this corpus luteum starts secreting progesterone. So now you saw that estrogen had proliferated the endometrium, but now under the influence of progesterone, these glands become more secretory, and that's why this is called also a secretory phase or a luteal phase, because it is driven by the corpus luteum. Now, should fertilization happen, the brain gets a signal, and then brain would allow corpus luteum to continue producing estrogen and progesterone to support the pregnancy until 10 weeks, when the placenta will take over the function. Should pregnancy not happen, the corpus luteum has a finite lifespan of roughly 2 weeks, and after 2 weeks the corpus luteum dies, and there is a sudden drop in estrogen and progesterone, as you can see, and that causes constriction of the blood vessels in the base layer of the endometrium, which causes necrosis of the top 2 layers. So the bottom layer, 1/3, is called stratum basal, the mid layer is called stratum compactum, and the top layer is called stratum spongiosum. So the stratum basal vessels are constricted because of drop in estrogen and progesterone, and the top 2 layers are sloughed off as menses, and the whole cycle starts over. And this corpus luteum, which is no longer functional, becomes sclerotic, filled with scar tissue, which appears whitish under microscope, and that's why it is called corpus albicans. Now, these are the changes happening at hypothalamus, pituitary, ovary, and the uterus. What is happening at the cervix? So in the first follicular phase, under the influence of estrogen, the cervical mucus becomes very thin and very watery, and it is to allow the sperms to reach the tube or uterus first easily. Whereas once the ovulation happens and the progesterone secretion starts rising. Under the influence of progesterone, the cervical mucus becomes really, really thick, and this creates a barrier for any additional sperms which will try and get into the uterus after the pregnancy has happened, or as well as this thick plug will turn into a mucus plug which will protect the gestational sac uterus from the vaginal bacteria and fungi as well as external organisms. And when a woman goes in labor, when the cervix softens, this mucus plug is released, and that's what we call show. Okay. So I hope that this helps you understand menstrual cycle in a better way. If you like the lecture, please like it and subscribe it. And if there are any particular topics you need to be covered, please do let us know in the comment section, and we'll try and get it sorted as soon as possible. Thank you.